Case Studies in Sexual Health with Dr. Marguerite Thomas. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For myself on the Central Coast, that is Darkinjung country, and I'd also like to pay respect to elders past, present, and emerging. Now, basic things about vertical integration. It will be recorded and available for you to view in our education library in a few days' time. We'd love the session to be interactive and for you to contribute, so please feel free to keep your cameras, microphones on, off, whatever suits you. Utilize the chat group. Chris is going to be facilitating the questions and comments coming in. And now we will hand over to Dr. Marguerite. I'll get you to know a few things about her first in her little intro, and then she will take over. So Marguerite Thomas is a Term 2 GP registrar at Terrigal Medical Centre, and she completed her internship and residency here on the Central Coast and has a background in public health policy and research. Now, good morning, Marguerite.
Good morning. Hi, everyone.
Now, a few questions for you today, just so we can get to know you and a little bit more about you. First question today is, what led you to study medicine?
Yeah, so I guess I kind of came to medicine as a postgraduate student. So I'd previously had a career in public health, specifically in policy. So my undergraduate was in psychology, and then I kind of had this realization that most of my clients really were more affected by the kind of structural upstream social determinants of health. And so I thought, okay, well, maybe that's where I should go. That's what I should be doing. And so I went and I worked down in Canberra at a very kind of high level policy framework kind of point in the system. And then in my mid-20s, I kind of had a crisis and I thought, oh my God, I can't actually sit in this ivory tower for the rest of my life. I need to actually go and speak to people. And so then I went to medical school, and I guess, now I'm at the front, at the bottom of that, stream in terms of addressing the kind of first downstream aspects of social determinants. So that's what brought me here, basically.
Yeah, beautiful. Now, when you say brought you here, why the Central Coast? I know that you said that you studied here, but why specifically the coast?
Yeah, so I did my postgraduate med in Sydney, but I'd always wanted to move out of Sydney and particularly to a coastal area. And I guess, the Central Coast is amazing in that it has all the benefits of being regional. So it's, quiet, there's a nice pace of life, it's obviously beautiful, beaches, nature, etc. But then it's so close to Sydney, so if you need to go in and have that big city experience, you're only an hour away. And, I have two young boys, so I have 2 kids under 4, and so I really wanted somewhere that I could give them that kind of neighborhood community sort of feel. And so the coast seemed like the right place to come to.
Yeah, beautiful. And also leading in, congratulations on 2 little boys. I'm sure that's a handful. How do you balance like the family work-life balance, I guess? Because I know they're quite young, and like you said, term 2, like
yes, I'm still working that out. So so I said, my 2 boys are 17 months and 4 years old, and I work full time. Possibly inadvisable, it's a lot, but I guess you just kind of do it, don't you? And I'm so fortunate that like I love my work, and so it makes me feel like I've got something more to contribute to them, because I go away and I get to do my own thing, and then I come back refreshed and like really ready to be present for them. And I guess GP training is probably the most flexible of medical training programs, so there is kind of the scope there to have more flexible working hours and not being on after hours rosters necessarily if you don't want to. So yeah, I guess the juggle is kind of a constant battle, and I don't think that's going to change probably, really, but we're doing it, so yeah.
Not until they move outside of home, right?
Yeah. But even then, right? Even then, I have patients who are like, I still worry about my 30-year-old. So yeah.
Oh, well, you're doing great. I will hand over to you for today's discussion.
Great. Okay. So hopefully everyone can see my screen. Or can you see the display on it?
Yeah, all good.
Yeah, okay, great. I'm sorry, what's just happened? Resume slideshow. Okay, so like I said, we're going to be discussing case studies in sexual health today. Just a disclaimer, obviously, are you seeing my next slide, or seems like maybe it's
not yet.
Give me a second, something's gone a bit strange with my PowerPoint. Here it is. There you go. Okay, so there we go. So obviously, given that this is an incredibly sensitive topic, I have really altered a lot of the details to keep patient confidentiality preserved. So I've changed names and genders and ages and sexual orientations. So just so you know, there have been no identifying details in the cases. And we'll just get straight into it. So my first case is a woman named Jane. So I had never seen Jane before. I had a quick look at her file before she was brought into my room. She's 31 years old. She's got no real significant past medical history. She's maybe had a couple of IRTs, maybe a UTI, but really not much in the history to know about Jane. So I bring her into my consult room and she says, you know, doctor, this is really embarrassing, but I've been sent this text message. And you can see the text message on there. So it's a text message from the Let Them Know website, which hopefully many of you will be familiar with. It's an anonymous contact tracing website, which we'll talk more about when we get to the contact tracing section. But the text message says, Jane, my syphilis test is positive and I'm sending you this anonymous SMS because I'm concerned that you may be at risk. Please go and get a text. So that's why she's come to see me today. So just a little bit of an update on syphilis. I think many of you will have gotten the public health bulletin on this recently, but syphilis is on the rise. So it's still predominantly highest in the population of men who have sex with men and in Aboriginal and Torres Strait Islander communities, particularly in remote locations. But there is now concerningly increasing prevalence in the general population and in particular in women of reproductive age. Which is really concerning given the risk of congenital syphilis. And we've actually had now an increase in our congenital syphilis rate. So there had not been a single case of congenital syphilis in New South Wales since 2013, and we're now starting to see some. And obviously, given the significant neonatal morbidity and mortality associated, this is a real public health priority. All right. So because I don't know Jane, first off, I'm going to obviously get some history from her. In particular, I'm going to start taking a sexual history. Now, for those of you who've been practicing for a long time, I'm sure you'll be very comfortable taking sexual histories, but maybe for some of the registrars or medical students or people who don't take sexual histories on a regular basis, I thought I'd just kind of talk through some of the best practice as per the STI guidelines. So the goal really in taking a sexual history is to try and stratify your patient's individual risk so that you can then rationalize your testing and treatment regime. And in particular, I've copied here the priority populations from the New South Wales STI strategy. So these are the kind of demographic groups that we really want to be identifying and making sure that we're targeting our testing appropriately for them. So it's not really surprising. It's people who've previously been diagnosed with an STI in the last 12 months because they're obviously at increased risk of recurrence or subsequent STIs, men who have sex with men, young people, Aboriginal and Torres Strait Islander people, pregnant women, sex workers, trans and gender diverse people, and then also people from culturally and just linguistically diverse backgrounds, particularly migrant and refugee backgrounds. And so the goal is that you want to try and identify if they're part of this group, and then also talk a little bit about the sexual practices and maybe associated behaviours that might place your patient at higher risk. The STI guidelines, which really, if I had to summarise this talk in one word, it would be go and read those guidelines if you ever are doing STI testing, because they're very clear, concise, and really easy to use. So they've got great suggested language. So if you're trying to, find, work on how you might ask these sensitive questions, they've got some suggested things that you might use, which I think are quite good. So to kind of start it off, they've got a broad statement like, I'd like to ask you some questions now about your sexual history so we can decide what tests to do. This information is confidential and it's okay if it includes partners outside of your current relationship. And then it's given you a series of ways of asking all the kind of screening questions that you need to know. So have you previously been diagnosed with an STI? When was the last time you were screened? When was the last time you had sex? And that's so you can work out incubation periods and window periods. Was that with a casual partner or a regular partner, a mix of men, women, both? Other than your regular partner, have you had sex with anyone else? And then when you had sex, was it vaginal, oral, or anal sex? And that's to try and guide what kind of swabs you might need to do and what areas of the body you might need to examine. When was the last time you might have had sex without a condom? For women of reproductive age, of course, you're going to ask about contraception, pregnancy status. And then I guess, as always, we just want to be mindful of using gender-affirming language with our trans and gender-diverse patients. So the suggestion would be, do you have any preferred terms for your genitals that we should use so that you try and, not use dysphoric language for them. All right, and then what I like to do, instead of kind of rapid fire throwing all these different demographic groups at patients, I often pull up the STI guidelines in front of the patient and get them to have a read through and just say to them, do any of these apply to you, or are you, do you feel like your partners might have any of these demographics or risk factors associated with them? And I think that's kind of a good way of not being too confronting, but making sure that you are covering all of those priority populations that you can see there. Okay, so my patient Jane, so she tells me that she has had 3 male sexual partners in the last 6 months. She says that she usually uses condoms, but she is worried that she's had some inconsistent use with 2 of the partners. She's on the contraceptive pill and she reports that she's been compliant with that. She has had oral, vaginal, and receptive anal intercourse variously with these 3 partners. She doesn't identify with any of the higher risk populations. And she last had an STI test in her mid-20s and it was negative, and she's never tested positive before. So she's 31 now, so it's been quite a while since she's last been screened. And she is up to date with her cervical screening test, and it was normal. And crucially, I think for her, she is asymptomatic. So she has no vaginal discharge, no pelvic pain, no pelvic bleeding, no urinary symptoms, no genital rashes or lesions. So, I mean, I think, if we're kind of stratifying Jane's risk, obviously she's a confirmed syphilis contact. So that's the main thing that we need to be thinking about. But she is also a woman of reproductive age. She has had 3 partners, so that has some implications for the contact tracing that she's going to need to do. And she's had some inconsistent condom use, but she is asymptomatic. And so the next question is, well, okay, what do we test for in this patient? Apart from syphilis, which we're obviously going to test for, does anyone have any ideas about what else they might try and prioritize in this 31-year-old woman? Just trying to...
I think people are just typing at the moment. Oh.
Yeah, sure.
Cool. So we've got pregnancy, so beta HCG.
Yeah, definitely.
If I can spell. Don't worry, I didn't notice, Georgia.
Anything else? That's all right. So I will.
Oh, here we go. Chlamydia and gonorrhea.
Yeah, definitely. Yeah, so I'm not sure if people are familiar with this testing tool. It's excellent. So this is the New South Wales STI HIV testing table, and I apologise, it's a bit small for you, but essentially it will stratify people into different risk groups and then advise what the appropriate testing would be. So they've got a specific section for young people. Jane's kind of just out of that group at 31, but I'd probably still consider her to be in that that same kind of risk group. And then they've got the kind of standard asymptomatic testing for everyone who comes in and says, I'd like STI screening. And then they break it down according to different risk groups. Aboriginal and Torres Strait Islander people, men who have sex with men, sex workers, people who inject drugs, pregnant women. So in Jane's case, of course, we're going to test for syphilis, but we should also really be testing for chlamydia and gonorrhea, and everyone should be offered the opportunity to screen for HIV. And then hepatitis B, you would test for if you were unaware of her immunisation status, or if you have no documented immunity to Hep B. So in her case, I didn't know whether, I mean, she told me that she'd been immunised as a baby, but we didn't have any confirmed serology to say that she had immunity. And so we'd add in Hep B as well. All right, and then I guess just a note about consent in this space, because obviously this is a really personal space that has a great kind of implication for the social kind of implications, I suppose, of this testing beyond the patient in front of you. So patients really should be explicitly consented to STI screening. So they should know what you're testing for and why, and then they should have some idea of what the personal implications of a positive test are. And again, the language from the STI screening guide is, I suggest we test for chlamydia. This test will involve a urine test or a vaginal swab. Chlamydia is easily treated, but people don't often know they have it. So are you happy to have the test? And if it's positive, then we will talk about having your recent partners tested as well. So just ensuring that we do that informed consent when we do our STI screening. All right, so as we've said, we're going to test for HIV, syphilis, Hep B, and then chlamydia and gonorrhea. And then how do we do it? Again, the New South Wales STI screening guide has a really clear kind of framework as to how you collect the right tests for this. But essentially, you're going to do the HIV, syphilis, and Hep B with bloods, and there's different specific Hep B markers to work out, you know, their immunisation status versus active disease versus past infection. And then for chlamydia and gonorrhea, you have the option of either doing urine or swabs, and those swabs can be for a female patient, either a vaginal swab that is clinician or self-collected, or an endocervical swab if you were already doing a speculum exam, or a first pass urine. Now, the first pass urine is not a first void urine, so it doesn't need to be the first urine of the day. It just needs to be the first volume of urine that they pass when they go, when they void. If they're symptomatic, then you should be swabbing the area that is symptomatic. So if they've got any throat symptoms, urethral symptoms, anorectal symptoms, then you'll swab that, that area. Specifically, if you were worried that there was maybe like a syphilitic chancre, so that early kind of primary syphilis marker, which we'll talk more about in a minute, then you want to be swabbing that with a PCR swab, because it can be the case that in very early infection, you'll get a positive PCR swab prior to getting positive serology on the blood. So if there was a negative blood but a positive swab, then you would go on and repeat that serology again in a couple of weeks and presume that they have syphilis. All right. And I guess in terms of whether or not you do urine or vaginal swabs for the chlamydia gonorrhea, the swabs are more accurate than the urine, but the urine is still got quite high sensitivity and specificity, so it's still a very good test. Okay, so Jane elects to have bloods and also to do a first pass urine. We do a urine pregnancy test and it is negative. And then from the STI screening guidelines, we presumptively treat all sexual contacts from people who have been contacts of someone who's had primary or secondary syphilis in the past 3 months, regardless of their serology. And so I'll go more into treatment in the next few slides, but before we send Jane off on her way to go and have her bloods, we give her 2 jabs of the benzodiazepine benzylpenicillin, and then we wait for her test results to come back. So while we're waiting, just talk a little bit about syphilis in general. So syphilis is a bacterial infection. It's caused by the Treponema pallidum bacteria, which is a spirochete. It is transmitted via skin-to-skin and mucous membranes, and there is also vertical transmission possible from mother to fetus. And as we've discussed briefly before, congenital syphilis is one of the torch infections with devastating neonatal and morbidity and mortality to be screened for. So clinical presentations of syphilis. Syphilis is known as the great imitator. So there's kind of, it's a really tricky thing in some ways to diagnose, because 50% of people will have no symptoms whatsoever. And then the other 50% of people can have kind of any symptom. So there are widespread different manifestations of syphilis. So there are dermatological symptoms, neurological symptoms, ophthalmic, cardiovascular, systemic symptoms. And really, actually, the STI guidelines even say you should consider syphilis testing in all patients with any unexplained symptoms. So anyone could have syphilis in theory, because it's so variable in the way that it presents, and often is asymptomatic anyway. All right, so in terms of infectious syphilis, and what you would see if you were going to have clinical signs of syphilis, so non-asymptomatic patients. And also just to note, these are not my patient images, these are from the Melbourne Sexual Health Centre STI Atlas, which is publicly available images. So first of all, you have primary syphilis. Primary syphilis is marked by development of a chancre, which is a single painless ulcer that's usually on an indurated firm base at the site of entry of the bacteria. So it could be on the penis, cervix, or mouth. And if it's on the genitals, then they will also often have inguinal lymphadenopathy. And I mean, I guess because it's painless and because it's often in sites that you can't actually visualize, like for example on a cervix, you could see how you could so easily miss this, as the patient would just not feel it and not be aware that they had it. And then without treatment, it will resolve within a few weeks by itself, right? Then the secondary syphilis usually occurs around 6 weeks post-infection, and this is when they would present with systemic signs and symptoms. So they might have fever, malaise, headache, lymphadenopathy. If they're going to be symptomatic, the skin is involved in around 90% of cases. So they get this kind of generalized rash over the trunk and then classically over the palms of the hands and the soles of the feet. And you can see some images there. It's quite a non-specific rash. Like you could see how it would be easy to confuse that with like a, guttate psoriasis or scabies or something. There's lots of rashes that kind of look like that. The other thing they can develop, which is a little bit more obvious that it would be syphilis, would be condylomata, which are these kind of wart-like genital growths that you get. And then they can have the neurological signs and symptoms. So cranial nerve palsies, vision changes, hearing loss, meningitis. And again, even with secondary syphilis, if it's untreated, it still will probably resolve over a few weeks, but then the risk is that they'll have a reoccurrence of symptoms. So they can have this kind of episodic resolution and then flares of it. And then tertiary syphilis, we really don't see very much in Australia at all now, thankfully, because we have good treatment for it. But tertiary syphilis is marked by significant neurological disability, so dementia, gait abnormalities, neuropathic pain, sensory deficits, these really horrific destructive lesions called gummas, which are these kind of destructive, ulcerating, granulomatous lesions of the skin, bones, and apparently the internal organs as well. And then they can have really quite catastrophic cardiovascular consequences, so aortic aneurysms, coronary arteritis, significant risk of serious cardiovascular disease. Are there any questions about that at the moment so far?
No questions.
No questions. Okay, excellent. All right. So I might move on then and just talk about how someone would progress through those stages of syphilis. So, I mean, I guess those 3 stages that I was talking about are symptomatic infective stages, but a lot of the time in untreated syphilis, there are latent phases where there's no symptoms at all. So you go from having exposure to incubation to primary syphilis, and then on to secondary syphilis. And then you can kind of go in and out of secondary syphilis and early latent syphilis. This diagram says for the first year, but that's an American diagram. In Australia, we actually mark it as being 2 years. So kind of the first 2 years, you can have these on and off periods of being symptomatic. And then after that 2-year mark, then we call it latent syphilis. And then it's often decades before they will progress to tertiary syphilis, and hopefully you would have treated and prevented that from occurring. I think what's interesting to note is that neurosyphilis and also the ophthalmic and auditory symptoms of syphilis can actually occur as early as that primary infective phase. So I mean, while it's much more common in the tertiary setting, it can actually occur fairly early on in the piece as well. All right, so testing for syphilis. So interpreting syphilis serology is actually quite challenging potentially because it can be confusing as to whether or not they've got active infection, treated infection, or active infection that's suboptimally treated. So it's a bit technical, but the lab basically will initially run a syphilis-specific antibody test called a CMIA or an EIA test. And if that's positive, then they do secondary testing. So they'll do confirmatory testing with the TPPA, which is the Treponema pallidum particle agglutination assay, for those who are interested. And also the RPR, which is a rapid plasma reagent. And those 2 tests are markers of disease activity and also treatment response. So this little flowchart here is taken from the ASHM syphilis guidelines. So ASHM has this really great interactive tool that you can click through online, and you put in, your result, and then it just quite talks you through the process of what to do. So I find it a bit hard to read these flowcharts and make sure I'm doing the right thing, but that click-through tool is really useful. So I would recommend that if you do ever come across positive syphilis serology, you would utilize that. And I guess if you're unsure, then you would speak to a specialist in sexual health. All right. So treatment, the recommendation is that if you have someone who's positive for syphilis, you do seek specialist input before you commence treatment, just to make sure that you've got the support of the public health unit behind you to treat them appropriately, and also to ensure contact tracing occurs appropriately. So really you would be reaching out for help at this stage just to get some advice around this. But the treatment's actually really straightforward. So it's just benzene, benzylpenicillin. And note that's not the same as the short-acting Ben-Pen that we would probably be more familiar with. So this is a specific long-acting formulation of it. There are apparently some shortages of supply. So if you have issues sourcing it, then the suggestion is to speak to the public health unit about where to make sure that you can get the right injection for your patient. And the number of doses that you're going to provide to your patient depends on the duration of their infection. So essentially what this flowchart is showing is that if it's early syphilis that's less than 2 years in duration, they only need 1 stat dose usually to have curative response. Alternatively, if it's late syphilis or we don't know the duration of infection, then they're going to have 3 doses, so 3 weeks, 3 consecutive weeks of 1 dose per week. So basically it comes in a 1.8 gram, comes in 2 injections to make up the 1.8 grams that you need. And you're going to repeat the serology on the day of treatment so that then you have a baseline of that RPR, which is that disease activity marker, in order to monitor your response to treatment.
Marguerite, there was a comment here from Gordo. He said, yeah, great point. It's I think this is to do with serology. It's really confusing.
Yes.
Be prepared for patients with previous syphilis diagnosis to take longer for their results to come back, as a secondary confirmation to check if syphilis is active or not is often done reflexively by the lab or the clinician.
Yes, yeah, that's right. Yeah, so the lab has protocols about adding on that secondary test, so you don't need to request it. But yes, I think it does. They do need to do a whole lot of different checks and balances in order to make sure that they have accurately confirmed, helped you to kind of tease out whether this is a new infection or an old infection, and whether it's active at the moment or whether it's been adequately treated and there's not a lot of disease activity. Yeah, thanks.
So as a tip, so when we order, so we would just order syphilis serology. Yeah, this is what I do. I hope it's right. And then I just rely on the lab to work out the RPR stuff.
Yeah, that's right.
Yep.
Yeah, exactly.
Exactly.
Yeah, that's what they suggest. I think it's probably a bit beyond, because you don't even know what particular, like every lab probably has its own slightly different testing protocol. So I think, I would leave that in their hands to make the right call on that. And I guess if there was any concern and you didn't, you were confused about a result, then, you could use that ASHM testing tool to kind of guide you through what to do next. Okay, so further to your management. So after you've administered your benzylpenicillin, then you're going to monitor and advise your patient that they can commonly get this reaction to it called a Jarrett-Herxheimer reaction, which is benign, but 6 to 12 hours post-treatment, they can get this kind of headache, fever, malaise, rigors, joint pain presentation, which can last for several hours. You just kind of need to support them with analgesia and reassurance. And I guess crucially from a public health perspective, you want to really get on top of contact tracing and reinfection and things like that. So you're going to advise them to have no sexual contact for 7 days after treatment has been commenced, or if they're on that 3-dose course until the course is completed and they're asymptomatic. You're also going to advise them not to have sex with partners from the last 3 months if they've had primary syphilis, 6 months if they've had secondary syphilis, or 12 months if they've got early latent syphilis, until all of those partners have been tested and treated, because you want to try and make sure that there's no risk of reinfection. Of course, this is a notifiable condition, so you would notify New South Wales Health. There is a syphilis notification form. I'm told that in practice, actually, they are more likely to have contacted you before you get to contact them. So the lab will make a mandatory report to public health, and then my understanding is that public health often will contact the referring GP to try and give them the support they need in terms of management. But if that doesn't happen for whatever reason, then you contact them, and there is a form that you can use online. All right, and then contact tracing. So contact tracing is so important from a public health point of view. It's really probably one of the most important things that we could do in terms of infectious disease management. So what you need to support your patient with is to contact trace back their sexual history based on the clinical stage of infection. So if they've got primary syphilis, then you're going to speak to all their contacts from the past 3 months, plus whatever duration of symptoms they may have had if they've been symptomatic. Secondary syphilis, it will be 6 months. Early latent syphilis, it will be 12 months, or from their most recent negative test. And late latent syphilis, you're going to test all of their current partners, and if in doubt, then you treat them as early latent syphilis. And I guess, of course, contacts of our pregnant patients are the highest priority because of the risk of neonatal syphilis. So if you've got a pregnant woman who's positive, you really need to ensure that everyone who she is having ongoing sexual contacts with has been tested and treated. And the great contact tracing services for people who feel like they can't have that discussion with their partners and would like to do it anonymously, as we saw in the case with Jane. So there's the Let Them Know website, which is kind of a general population one. The Drama Down Under is specific for men who have sex with men, and has a lot of men who have sex with men specific resources on there for people who have been contacts. And the Better to Know website is culturally safe for Aboriginal and Torres Strait Islander people. So if you had an Aboriginal patient, that might be the most culturally appropriate website for them to use. Any questions? Not at the moment? All right.
Yeah, no question. I've just put up a link. I think that was a really important point you made about the notifiable medical conditions, because it's often something we're not aware of when we first start in general practice. So I've shared a link of the New South Wales Health notifiable conditions, and it's got syphilis, and then the web page has that link you were talking about with the form. But yeah, and just determining what's lab notifiable versus doctor notifiable. So yeah, it's great.
Oh, and also, Marguerite, Michael, our registrar, stated that he, at his previous practice, had a patient with syphilis, and he was actually sent by the New South Wales Health the syphilis notification form.
Yes.
To complete. So they obviously have that automatic lab notification, and then they followed up with a form being sent through.
Yes. Yeah. Exactly. Yeah. Okay. Excellent. All right. So follow up. So we need to follow up with these patients, obviously, to confirm that they've had all the treatment that they require, to ensure that you've done the contact tracing and offer more support to them if they need it, and then to basically test to see if they've had good response to treatment. So for our patients who have tested positive for syphilis and been treated for it, so you're going to repeat that serology at 3 months, then at 6 months, and then if they are still positive or if it's still high, at 12 months as well. And what you're looking for is a 4-fold drop in that RPR rating, which would indicate that they've had an adequate response to treatment. And if you haven't got that, then you would be seeking specialist advice to try and work out what to do. All right, so back to Jane. So Jane's results come through, and she is negative for syphilis. So we've already presumptively treated her anyway, but she is thankfully negative for it. Her hepatitis B serology shows that she's not actually had immunity from immunization. I'm not going to talk more about that, but basically she needs a booster series of Hep B. But what has come back positive is that she is positive for chlamydia. So bit of a plot twist, and this is why I guess when we do STI screening, we look holistically and we try and make sure that we're not missing things. So I'm going to talk a little bit about chlamydia now. All right, and I'm just conscious of the time, so I will try and speed through a little bit, all right? So chlamydia is our most common reportable communicable disease in Australia. I think, I was wondering if maybe it might have been COVID more recently, but anyway, that's what the STI screening guidelines say, and I haven't fact-checked them, so it is very common is what we need to know. And importantly, it is usually asymptomatic, and reinfection is really common because past infection does not confer immunity. So it is very common to have multiple chlamydial infections within the same patient. And it will affect the urethra, the cervix, the eyes, the oropharynx, and also the rectum. So 85 to 90% of people with chlamydia have no symptoms at all. If they do have symptoms, they are typical kind of urogenital symptoms. So dysuria, discharge, vaginal or penile, testicular pain, pelvic pain, abnormal menstrual bleeding or postcoital bleeding, painful sex or anal rectal symptoms. And while most people are asymptomatic with chlamydia, the complications of chlamydia can be significant. So they can develop epididymal urachritis, pelvic inflammatory disease. There are implications for fertility, and they can have tubal damage and ongoing tubal infertility issues. In the context of a pregnancy, chlamydia infection can increase the risk of ectopics. It can cause abnormal low birth weight, premature rupture of membranes, preterm delivery. So needs to be treated. Can also cause kind of reactive arthritis picture with, rash and gastro symptoms, cervicitis, conjunctivitis, and perihepatitis, which I've not seen, but it can happen apparently. So we've already spoken a little bit about how you diagnose syphilis. So that's that first pass urine or the swabs. And again, just making sure that you're asking your history about symptoms in the throat, in the anal rectal region, because that would change the areas that you swab, and also for anal rectal infection, the way that you treat. Management of chlamydia is really straightforward again. So for uncomplicated genital or pharyngeal infection, the preferred method of treatment is doxycycline for 7 days. If you've got concerns about compliance with that, then you can use the azithromycin, but due to concerns about azithromycin antibiotic resistance, the preferred form of treatment is the doxy. So go with that if you think you've got a patient who will follow it. If you've got anal rectal infection, there's some special kind of additional testing, additional treatment that they might need to do, just because it's a little bit harder to clear. And again, you're going to advise them to have no sexual contact until 7 days after treatment is commenced, or until the course is completed and symptoms have resolved, so whichever is later. And you're going to go through and contact trace back partners for the past 6 months and make sure that all of them have been tested and treated if necessary. Interesting thing which I came across in my reading, which I was unaware of, but there is an option in New South Wales to do patient-delivered partner therapy, which is basically that you can prescribe a supply of azithromycin for partners of patients with genital chlamydia if it is unlikely that that partner is going to present for care themselves. And there are some guidelines from New South Wales Health about how you go about doing that. So if you think you've got a patient who that might be appropriate for, then I think you can read about that, discuss it with the public health unit. Yeah. Has anyone done that before? Has anyone done any patient-delivered partner therapy?
I usually have got them to come in, so
yeah,
talk to me about it. But I know colleagues have done it.
Yeah. I mean, I think if you can get them to come in, then obviously that's preferable, because then you can have a discussion with them and probably do further STI screening. And probably they're the type of patient who you could have lots of discussions with. But yeah, if it's not going to happen, then I guess that's always an option for you.
There's a bit of chatter in here. So Kelly's mentioned she's done it twice, and she was just saying that, yeah, tourists won't come in because they don't have Medicare. You know, if it's overseas tourists and stuff, they don't have Medicare cards. So it's a really good point about access and you know, and cost of healthcare. And Gordo said, no, I've not, but I think it was put in place during COVID lockdown. I was just going to mention, there was a question back just about the syphilis, just with Jane. If we just jump back to Jane's syphilis result, there was a question about whether we need to repeat it. And I was going to say, I think we would. There's a nice decision-making tool, which I'll put a link to, which says, I put it through and it said, a negative syphilis screening assay excludes syphilis contracted more than 12 weeks before the day of the test. Repeat the test in 1 month if there's a high risk of recent exposure. But it was hard with Jane, wasn't it? Because we don't actually know. She's had 3 partners. We don't know who the partner is, so we don't know what the when the exposure was.
Exactly. So exactly. So and I have a slide about that. I am actually due to have my follow-up with her. I think next week, and we'll retest for that, and we're also going to do her 3-month chlamydia clearance test as well at that point in time. So so we've got follow-up for chlamydia. So reinfection is common. So the suggestion is they don't necessarily need a test of cure, but you should be retesting them again at 3 months to make sure that they haven't been reinfected. I mean, even though you've told them not to go back and see their partners from the past 6 months without having them being treated, things happen. So the suggestion from the STI guidelines is to ensure that you do go and retest them again at that point. The exception would be if they're pregnant or if they've had anal rectal infection treated with the Zithro, and then you really need to do a test of cure for them. So yes, case conclusion. So Jane was treated with the doxycycline for her chlamydia, and she is now due to have her follow-up chlamydia test as well as the follow-up syphilis test as well. All right. In terms of the kind of key learning points to talk about from there, so syphilis is on the rise, and we really should have a very low threshold to test, especially in pregnancy. So the recommendation now is that you should be testing for syphilis both in your early antenatal bloods and then again at the 26 to 28 week mark. And even for women who are at high risk, I think they're also suggesting it would be appropriate to do it at the 36 weeks as well. Syphilis is the great imitator. So 50% of cases are asymptomatic, but the other 50% can present in a very wide variety of ways. Seek specialist input about interpreting positive syphilis serology and planning treatment, just because it is can be a bit confusing to ensure that you've done the right thing. Chlamydia is the most prevalent reportable communicative disease, but 85 to 90% of cases are asymptomatic. So we should really be doing our screening for young people in particular for chlamydia. Treatment for both of these is really quite straightforward and effective. And of course, contact tracing is really key in this space. And then I've just put up some key resources that I've used as references for my talk. So I don't know if people regularly refer to the STI management guidelines, but they're just so great. I think they've done a really good job of putting those together. The ASHM decision-making tool, also excellent. And then those contact tracing websites. And of course, you have the specialist centre at the Sexual Health Clinic. So that's my talk. I hope it was useful. Are there any questions? Anything that I can help with?
Yeah, no, great talk. Thanks, Margaret. It's really good to refresh this these presentations. I'll let everyone have a chance to write any questions in the chat. Gordo, you come on screen. Do you have any questions or comments?
Oh, no, not at all, actually. I was just kind of saying, well done.
Can we say hi?
I really enjoyed
Cool.
that. Yeah, and I was just typing a message, but I was just trying to say it. Thanks for the reminder, so too, because one of my patients who tested positive for syphilis this year, he's due for his 3-month checkup. So sending a message just there beforehand. So yes, remember.
Good. Yeah, good. Yeah.
Thanks, Margaret. That was great. A great refresher for now. I was saying I'm a bit old school now, and the guidelines change, so it's good to check them every few years and come up with supplies.
Exactly.
Whether it's guidelines or therapeutic guidelines, but all the
Yeah.
new were up to
It's
date,
tricky.
but not us older ones now. So
Especially like azithromycin, you just have that in your head as, oh, that's quick and easy. It's 2 tablets.
Yeah.
And now doxy, it's just a little bit more complicated and for
Yeah.
the patient.
Yeah.
And
Yes,
with the
unfortunately, the
pregnancy screening-
resistance.
Mm.
So with the pregnancy screening now with syphilis, is that in the actual guidelines now, the 26 to 28 weeks? Because
Yeah, I was looking for that too.
Yeah.
Yeah,
It is.
so I read that on the New South Wales Health Syphilis Bulletin. So I'm not sure if RANZCOG's put that in their guidelines, but certainly if you look at the New South Wales syphilis testing guidelines, they've got it there. Yeah, and I'm not sure. I'm not sure if they're doing that now in hospital. I mean, they should be doing it, I guess, in the antenatal clinic. I haven't been there this year, so yeah.
Yeah, it's interesting.
And
It wasn't on my
we are
radar.
actually.
I've just looked it up.
Oh, sorry, Chris.
Sorry, go.
No, talking about doing syphilis screening in our midwifery clinics, etc. We actually were declared one of the hotspots ourselves on the Central Coast. So that's why they actually have been having a bigger push for that to be done. And that was actually in a presentation given by the RSGP recently with Kim Collins, who's one of our local sexual health physicians, who was actually presenting that night.
Yeah.
Yeah, and it's definitely in H&E health pathways under syphilis. So the Hunter pathways, it's got it here, but it wasn't necessarily listed clearly under the routine antenatal care section. So
It's only just come through late last year.
Yeah.
Okay.
Yeah.
Just tricky, these updates, unless you keep looking at the guidelines, you're not aware of them. So it's interesting to do it at 26 and 28 weeks in a low risk patient with the same partner for many years.
Yeah.
You never know, Chris.
I know. I know, but it's
Yeah.
But also, so too, unfortunately, even though the pregnant lady may actually have a stable partner, it doesn't mean a partner actually has her as her only stable partner.
That's true. Yeah,
So
exactly.
that's
Yeah, I know.
unfortunately where the loophole does actually gets created.
Yeah, of course.
Yeah. I guess just the risks are so significant and the treatment is so straightforward that why would you not test? Like it's
makes sense.
Yeah, no, thank you so much for that today, Marguerite. I'm just going to hit the stop recording really quick.